And it's a great pleasure for us. I am Guilherme Macedo, the president of the World Gastroenterology Organization, and it is really an honor for me and our organization to partner with IFSO once again. We've done that last year, we've done that at the World Digestive Health Day, we've done that with the guidelines, and we still have much more to do. So, without further ado, let's begin. And then I have to say that we'll have the final discussion at the end of the presentations. I think it's the best approach to keep on time. So it is my pleasure now to present Violeta Moise from Spain to address the nutritional interventions in patients with liver disease and obesity. Thank you.
Thank you very much. Thank you for the opportunity of collaborate with WGO. I am going to consider the nutritional intervention in patients with liver disease and obesity, since as you, okay, this never happens. Okay, no conflict of interest to this class, and probably it's me doing it wrong. Okay, yes. Sorry about that, not going.
Can we touch screen or just the...
Yeah, can I just touch the screen?
Nope, doesn't work.
I mean, I'm pressing this. Am I okay? Ah, so I probably got the other one. Okay. Okay, so
Good.
Here. Sorry about that. So nutrition and dietary interventions are central components in the pathophysiology of this disease, but also they are cornerstone in the management of patients with non-alcoholic fatty liver disease. I am going to call them NAFLD. So balanced levels of dietary macronutrients and micronutrients can act to slow or halt the progression of non-alcoholic fatty liver disease. So an imbalance, let's say, a very high intake of sugar or an unproportional intake of fatty acids can, in fact, help to progress the disease. So medical nutrition therapy is good and intervening with these stages of liver disease where they are reversible, where it's able to find a reverse in any stage. So medical nutrition therapy is going to work on that, helping reverse that. And also, we are going to consider some aspects of the medical nutrition therapy in those patients with cirrhosis that are in the waiting list for the transplant. So here we can see the impact of key dietary nutrients of molecular mediators that orchestrate the core non-full pathological pathway. Carbohydrates, fatty acids, and amino acids can simultaneously either activate or block the central and critical nodes of the non-alcoholic fatty liver disease. So there is a consensus that weight loss through lifestyle modification significantly reduces these features of non-alcoholic steatohepatitis. We can see this study of Villar and Gomez, of Villar, sorry about that. Okay.
Forget the pointer.
Yeah, okay, here. We can see in this, I wanted to try the point, but I couldn't find it. No? Okay, here. Sorry. The correlation after the weight loss behavioral modification program is showing here there is a correlation between the weight loss percentage and improvement of different histological parameters related to NASH. So as much weight they lose, a better are the resolution of these complications. And in this graph here, that is from the guidelines, we can see the probability of NASH resolution, fibrosis regression, steatosis improvement, at least in some stages, that can be achieved after these lifestyle intervention programs and are proportionally, how I was saying, to weight loss. So, but reducing fat intake as a way to decrease caloric intake in order to lose weight is not the simple solution, since not all fat different, I mean, act the same in people with NASH or non-alcoholic fatty liver disease. In this study, we can see how the long-term adherence to the Mediterranean diet supplemented with extra virgin olive oil is associated with a low prevalence of NAFLD compared with a similar diet supplemented with nuts, so more polyunsaturated fatty acids, or with control diet. In this was from the Predimed steatosis sub-study, and for those that are not familiar with Predimed study, the aim was to explore the association with liver steatosis of the 3 different diets that I just mentioned. So as you can see, after the 3 years study, the proportion, the percentage of people under this diet was significantly lower than the ones with the other type of diets. So in the same way, this overfeeding study show how polyunsaturated and saturated fat causes different effects on liver and visceral fat accumulations. After the 7 weeks of randomized control trials, they both groups gained the same amount of weight, but those in the saturated fatty acid with palm oil, as in brown, markedly increased liver fat compared with PUFA and caused a 2-fold increase in this visceral fat, as you can see in this graph. So we also know that the benefits from the Mediterranean diet are going to occur independently of weight loss. This was shown in this study, also randomized control trial with MUFA versus other diet with carbohydrates and higher fiber intake, when they showed that both after this 8-week intervention, both groups didn't lose weight, but as you can see, the MUFA group was successfully decreasing the percentage of liver fat, both groups, with or without exercise. So the exercise wasn't really playing a role here too. So these are the plausible mechanisms, determinants of the beneficial effect of the Mediterranean diet. All those components are responsible for these benefits that decrease de novo lipogenesis, increase fatty acid beta oxidation, and also decrease insulin sensitivity, insulin resistance, insulin-resistant, oxidative stress, inflammation, and also fibrogenesis. So all these components, I added caffeine because there are some studies that are also relating the caffeine intake, not only by the caffeine itself, but of course by the polyphenols that are contained in coffee. So fructose was observed in many epidemiological studies that is related and promote hepatic steatosis, either because the increase in de novo lipogenesis that acts negatively with the full synthesis, but also because it causes changes in eating behaviors, increasing intake, leading to increased intake, and probably leading to overweight and obesity. So in this other study, we see how, we all know this, but increasing in soda consumption is associated with fatty liver disease independent of the metabolic syndrome, and also same people was doing worse with the drink consumption and the severity of fatty liver disease. So drinking soda, we know, and it's more than observed that it has a negative consequences. So a summary of the nutritional treatment options are shown in these slides. In these reversible stages, we know that weight reduction or isocaloric Mediterranean diet has been suggested by clinical trials, so are good to apply in our patients. We also are aiming for weight reduction, but in this case, stressing the 7 or 10% of weight loss necessary to go from NASH or fibrosis to fatty liver disease. This also was observed in many clinical trials. And regarding the other stages, medical nutrition therapy can also be offered, should be offered in patients in waiting lists for liver transplant in order to support weight loss and improve muscle mass. So we know that the risk of sarcopenia is high in patients with NASH and NAFLD, and also we know that there is a very high prevalence of overweight and obesity among this population, and so all these contribute to increased sarcopenia, and sarcopenia is also related to poor outcomes in these cirrhosis patients. So guidelines also suggest to develop a prehabilitation program with a multidisciplinary team and perform in centers with a specialized, multidisciplinary team. And some studies like this performed in 2022 show or suggest at least 8 weeks of intervention with nutrition therapy, focusing on protein intake, but also physical activity. And they also comment about a potential added benefits of the branched chain amino acids. In order to go deeply, a little more deeply in protein of the diet, the recommendations go through 1 gram to 1.5 grams of proteins by average body weight a day for people that are with compensated liver cirrhosis and malnutrition or sarcopenia. Well, this can be difficult to manage, but in programs, specialized programs can help to get this situation. So regarding how to get these recommendations to patients, well, there are some behavioral aspects of lifestyle modification that needs to be considered here. There is not enough knowing this information. We need to act on how to apply this and be able to influence in our patients' behaviors. So guidelines were developed for behavioral therapy in the lifestyle treatment of NASH. This guideline follows the motivational interviewing approach, patient-centered, and is, well, similar to this encounter in the Canadian guidelines that were published in 2020. So also, because it's important, well, to focus on this and how to manage this, I would like to share with you this culinary medicine course that we started in our institution for both healthcare providers and patients in order to help them increase skills to manage their diet. We believe that if we as therapeutics, as healthcare providers, eat well and eat like bluefish 3 times a day as is suggested for the Mediterranean diet, we're going to be able to transfer this to our patients. So I show this video. Please take the recipe because I am sure you will make it many times. It's a good way to eat bluefish during the whole year, and it's about a sardine burger. So I hope you can now see it.
Hacer una hamburguesa de sardinas en conserva.
It's in Spanish.
Para hacer esta receta necesitamos las sardinas en conserva en aceite de oliva, un poco de huevo y un poco de cebolla, perejil picado, algunos condimentos al gusto, en este caso un poco de orégano y un poco de comino, y lo acompañaremos con una ensalada de escarola, unos tomates secos en conserva, ajo tierno, sal, aceite y pimienta. Vamos a hacer las hamburguesas. Para ello ponemos las sardinas, que las tengo bien escurridas, casco el huevo y lo bato, y ponemos un poco de cebolla, un poco de perejil, una pizca de las especias y trabajamos con el tenedor para amalgamar los ingredientes. Lo condimentamos con un poco de sal, una pizca de pimienta y lo ligamos con un poco del huevo.
Putting some egg there to do the emulsion.
Y para darle la forma de hamburguesa, con un molde circular y un papel de cocina, vertemos en su interior la pasta de hamburguesa, sacamos el molde y la doramos por las 2 caras. Mientras, vamos a preparar la ensalada.
So we prepare some salad as side dish.
Vamos a emplatar poniendo la ensalada a un lado y ponemos la hamburguesa en el plato. Como veis, es una manera de comer pescado azul durante todo el año.
So this is, you see, very tasty. Try at home, please. Share it with your patients. And of course, it's a great way and cheap to eat bluefish. So as per conclusions, there is a potential therapeutic role of a high-quality, healthy diet to improve hepatic steatosis and metabolic dysfunction in patients with non-food, independent of caloric restriction and weight loss. This is very important. The limited data suggests that that the Mediterranean diet may be an effective dietary approach. So prevention and management of sarcopenia are also essential, so we can put all together in one program. We, of course, need more studies, but importantly, think about motivational interviewing with shared decision-making to promote adherence to Mediterranean diet. And that's it for me. Sorry for the interruptions, and thank you for your attention.
Thank you.
I'd like to introduce the next speaker. It's Francois Patou, who's going to speak on NASH and bariatric surgery.
Thank you very much for the privilege of the podium today. So, may I have the first slide, please? Okay, well, let's go there. So, as you know, NASH is a difficult disease to diagnose. It's a difficult disease to understand and to follow. So that's what we are going to talk about, because I think that the level of evidence has increased tremendously during the last few years. So, NASH and bariatric surgery. So first we have to acknowledge history, and there is a lot of study all around the literature that says or notice that NASH, or let's say metabolic associated steatotic liver disease, could improve after surgery. But we needed direct evidence. So the first piece of evidence came from our study with a prospective study with a longitudinal cohort with a repeated routine biopsy. So that's quite demanding for patients, but hundreds of patients went through. And so the two main results were that first, NASH can be reversed very rapidly after surgery. 1 year is enough to see 8 out of 10 patients without NASH anymore 1 year later. First results. The second result is that even fibrosis can be reversed. It takes longer. You need to take at least 1 to 5 years. And at 5 years, 2/3 of patients are out of severe advanced liver disease. So again, very important direct evidence that shows that liver disease is improving, and that is not known with drugs or any other treatment in that extent. So if you look now at very precise data that we have recently analyzed, it's just fibrosis remission, but in patients with advanced fibrosis to start with, so F2 and more. And we know that F2 patients are at risk of increased mortality and increased liver event. So these are the patients we are aiming. These are the ones at risk. And if you look at them, 1 year after surgery, you can see that nearly half of these patients with advanced liver disease don't have any more advanced liver disease. You can see even the very top of them with F4. Some patients, even if we don't like to operate patients with cirrhosis, had F4, cirrhosis, by chance on the liver biopsy at the time of surgery. And you can see cirrhosis reversed 5 years after surgery. And if you go 5 years, it's 2/3 of patients with not anymore significant liver disease or fibrosis. So that's the first piece of evidence. It's a secondary endpoint, but it's histology. Very important, this year, a few months ago, came the first randomized study that compared, from Geltrude Mingron in Roma, Italy, published in the Lancet a few months ago, that compared face-to-face in a randomized fashion a group of patients with NASH undergoing surgery with best medical treatment as the control group. And you can see that, again, same results were observed. We know that without surgery, it's rarely seen that NASH can disappear, but here, in per protocol, meaning that all the patients who had double biopsy, 70% without NASH at 1 year, 50% with improvement of fibrosis, a little less stringent outcome that I just told you, improvement of fibrosis at 1 year, but it's only 1 year. So again, in a randomized study, confirmation, direct evidence for improvement, and not only improvement, resolution in many cases of severe liver steatotic disease. Few words about diagnosis, because of course a biopsy is not the way to go. Liver biopsy is invasive. Our patient accepted in the research context to have double or triple biopsy, but of course that's not the way we are going to go for the large number of patients who are expecting surgery. So we need to go with non-invasive liver testing. This is just to remind you that there is already guidelines to try to, but this is tricky. For example, this ISMBS position just screen patients with NFS, which is a very widely used non-invasive score for the diagnosis of NAFLD. And you can see here there is several of them, but you can see that all of them, of these scores, use the same type of ingredients, but not exactly the same one. And of course, NFS is using BMI. So you can imagine that BMI is confusing the diagnosis in our patients. So if you do NFS in our patients, most of them will appear to have fibrosis, which is not the case. So it is now well recognized that NFS should not be used. So let's go to the others. So the others here you have in our cohort, in a recent review that we did, you can see that before surgery and 1 year and 5 years later, you can see that most of these scores are not so good. One of them, for example, FIB4. FIB4 includes age. So of course, when you have 5 years more, you cannot decrease your FIB4. FIB4 will increase after surgery. So this is a new world of monitoring remission of NASH with a non-invasive score. It's another business than diagnosis in a cross-sectional study. So that's a new area that is coming. So the two good ones are the two HFS, FNI, two scores that have been recently described that have included metabolic ingredients, metabolic variables in the calculation. And if we now look at diagnostic remission, so the same patient I showed you with fibrosis to start with, and we are going to diagnose those with no fibrosis, but let's try to do it without any biopsy. And if you do that, you can see that every score is confused at 1 year. This is telling us that these scores have been developed by statistical association. They don't tell biological direct link between the scores and the histology. So after 1 year, many things are changing. Fibrosis is decreasing, but the scores are confused. 5 years make them a little easier. But at 5 years, you can see that all of them are nearly correct. You know that 0.7 area under the curve is the limit to say that the diagnostic test is correct, but 0.8 is much better. And again, the two scores with metabolic ingredients do better. So just a word of caution in this new world which is coming, where we can treat NASH and metabolic associated steatotic liver disease. Be careful, it's a new world, so the old tools will not work. So just a summary that this fibrosis NAFLD index is somewhat the best of them so far. But this is an ongoing work. So just last word of caution, surgery is an invasive treatment. So we need to have in mind that the safety is a major issue for us. Of course, when you are doing dieting or lifestyle, maybe the efficiency is less, but the risk is, of course, much less also. So two ideas here. One is that when you have a patient with severe liver disease, including cirrhosis, you have patients with a lot more risk than usual. And this is on the left, a classical general surgery data, saying that if you are taking care of patients with, let's say, a MELD score, so we know that it's a severity liver score, above 10, which is not awful, your mortality risk, if you just do a lab chole, is nearly 5%. Mortality risk for lab chole. That means we are dealing with a totally different world. These patients with cirrhosis, especially if they are not compensated, are really patients we don't want to operate on. So we have a window which is quite wide, but that means NASH, little bit of fibrosis, but not decompensated window cirrhosis. The next important data is a good news, is that if you go for the big picture, and this is an American retrospective study from Armenian and colleagues that shows that if you take a little bit of perspective in the real life, the mortality, all-cause mortality and cardiovascular mortality in these patients with NASH will be better if operated than if not operated. So in the long term, it is much better without cirrhosis to operate patients with NASH. So if I am now just trying to reconcile everything, I think it's important to understand that we are needing randomized trial. One is already there. This is the first one to have published data. This is coming from Roma, from Jeltrude Mingron, just in red. I've shown you the most important of this data. But we are also 4 others randomized trials ongoing so far worldwide. One is in Lille, in our town, and coordinated in France, but others are in the States or in UK. And these studies are needed to reach the point where, like diabetes type 2, we can say safely that surgery has reached prime time, that surgery can be offered to patients just for NASH. Forget about BMI, forget about diabetes, just for NASH. And this is maybe several years to come. But if I'm now summarizing and just give you a take-home message, I think the thing important to understand is that the level of evidence has improved a lot. We are moving toward prime time for surgery for NASH, meaning that we are now moving from cohort study, even if it was prospective, it was not controlled, to randomized trial. And of course, when we will be on the left side, level 1A, several randomized trials, all converging to say the same message, then we can say that surgery is here to help to treat NASH and should be proposed to patients as a first option. Of course, remind that safety is a major issue and will remain a major issue. We should not harm patients, and we have to be very careful here, especially with patients with cirrhosis. Compensated cirrhosis is the upper limit we can go. And with that, I thank you for your attention.
Thank you very much. Very well done on time, and still, you know that you still have 5 minutes tolerance, not indulgence, but it was fine. Great, and we'll move now to another area concerning liver disease, which is the liver transplant. So, Rana Pulat from USA, welcome, and please tell us about the issues of timing of bariatric surgery in the liver transplant setting.
Well, thank you so much for the invitation, Professor Macedo and Professor Sikora. This topic is pretty close to my heart. I originally trained in liver transplant before switching to bariatric surgery.
I believe it's the other one. You have another one up there. Yeah. Oh.
So these are my disclosure slides. It has no bearing on my talk. So what's the scope of problem for NAFLD? Its global incidence is 32%. In the Americas and Southeast Asia, it's 40%. And NASH has 5% of the US population. It's the second most common cause for transplantation of the liver. It's going to soon be the most common cause for transplantation of liver. So what is the need for metabolic and bariatric surgery in this population? There's a high prevalence of obesity in the liver transplant cohort. The BMI is greater than 40 is a cutoff in most programs. Liver transplant is technically very challenging in obese patients because of the depth of the abdominal cavity. Immunosuppressive medications themselves are obesogenic, and immunosuppressive medications are also diabetogenic, and diabetes mellitus is an independent risk factor for graft failure. Obese liver transplant patients are high risk for metabolic syndrome and risk for cardiovascular events, and recurrence of NASH after transplantation is 30 to 100%. So what are the things you do for metabolic surgery before liver transplant? The assessment. Obviously, child's score has been there forever. The mortality for an A is 10%, the mortality for B is 30%, and C is 80%. It's ascites and encephalopathy are subjective, so you obviously have a better score, which is the MELD, that's more objective. And just to give you an idea, to re-emphasize what the previous speaker spoke, the mortality increase is 1% for every point increase below 20, and 2% for every point above 20. And MELD above 8 will give you a poor outcome. So what's the problem in operating on someone with portal hypertension? There's thrombocytopenia and splenomegaly, which will interfere with your surgery. Ascites has wound healing problems, not so much in the laparoscopic era. It also causes pulmonary atelectasis because of the pushing of the lung, so these patients do worse. There are also varices and shunts, and perioperative fluid shifts are affected by it. So if you have a hepatic venous wedge pressure of greater than 10, then that's significant portal hypertension. And the risks of TIPS should be weighed in these patients because some of the patients, if you do TIPS, can be converted to a decompensated hepatic encephalopathy. What are the disadvantages of doing metabolic bariatric surgery before liver transplant? There's a high risk of bleeding, can cause progression. Obviously, you're not going to take a decompensated cirrhotic. So if somebody has got a high MELD score, about 8, or a child's C, you're not going to take that patient and do metabolic and bariatric surgery. It can cause progression to decompensated cirrhosis and liver failure. If the patient leaks, then it may prevent the patient from qualifying for liver transplant because sepsis is a contraindication. If the patient leaks, it may make future liver transplant very difficult due to adhesions and the adhesion profile. The advantages of metabolic and bariatric surgery before liver transplant, it makes liver transplant less challenging because weight loss with bariatric surgery will give you a better body habitus. It also may help the patient get delisted due to an improvement in liver disease, and it may improve the chances of getting the patient listed because if you have a BMI greater than 40 cutoff and you can drop their BMI, they may be able to qualify for liver transplant. So this is a group from Mehrani and group had published about an overall, when they looked at metabolic bariatric surgery before liver transplant, overall complication rate was higher in the cirrhotic group, 13.6% versus 6.3%. Hospital length of stay was significantly higher in the cirrhotic group. There's a significantly higher 90-day post-op mortality in the cirrhotic group. However, the long-term mortality is equivalent between the two groups, and the total weight loss between the two groups at 12 months were equivalent. So how about combining metabolic bariatric surgery and liver transplant? The advantages during the liver transplant is that it's one operation, one hospital stay, so it's more economical. There is resolution of portal hypertension when you do the liver transplant. There's no adhesions because you're already open and doing the liver transplant. And insurance coverage or delays in approval for metabolic bariatric surgery, which are a significant barrier in the US, could be countered by this. And the graft has the best chance of avoiding de novo steatosis by doing it as a combined approach. What are the disadvantages during a combined approach? The complications from bariatric surgery can have severe consequences because of the immunosuppression. They can become more septic. Infection and bleeding are obviously a risk. Immunosuppression modification of complications from bariatric surgery. So you may have to stop giving them steroids. You may have to stop giving them thymoglobulin if they have rejection, hand sepsis, and then this may have an impact on graft survival. So Heimbach has the largest series of cases reported for a combined liver transplantation and gastric sleeve resection. This was the original study in 2013. Patients greater than BMI of 35 were enrolled, and 37 patients achieved weight loss and underwent liver transplant alone, compared to the 7 that underwent sleeve with liver transplant at the same time. As you can see, in the liver transplant alone, the weight gain to BMI was 35, 21 of 34 patients. The post-liver transplant diabetes mellitus was still there in 12 out of 34, steatosis 7 out of 34, 3 deaths and 3 graft losses. And in the combined group, there was a mean BMI had reduced to 29, no diabetes mellitus, no steatosis, no deaths, no graft leak. But however, they did have 1 sleeve leak, which they were able to fix endoscopically, and 1 twisted sleeve by which the patient could not eat well, and they had to put in a feeding tube and manage it that way. And you can see the BMI trends that all of them with the combined sleeve liver transplant seem to have a much lower BMI. How about a brief interval approach? This is another approach which has been suggested. Don't do it at the same time. You can do it at the same time of the liver, but in a lot of patients, they may have like bleeding. So you take the patient to the ICU, let the bleeding settle, open abdomen, bring them back, and when the bleeding settles, then go do the sleeve gastrectomy after when they are ready for you to do it. And they did 14 cases with 2-stage liver transplant and sleeve group, and 28 patients were the controls who had a 2-stage operation but with no sleeve gastrectomy. And the estimated weight loss at 1 year was 74% in the ones who had the sleeve group versus 15.8. The graft survival was 92.9% versus 89.3%, and there was no reintervention due to the sleeve gastrectomy itself. So this may be a feasible option of performing sleeve in a high-risk group of patients. This is just the pathology slide that shows you if you do a Roux-en-Y gastric bypass after a liver transplant, how you can reverse NASH, which is what the previous speaker was talking about. So following liver transplant, what is the safety and feasibility? This was first shown by Lin and group. There's comparable weight loss with non-liver transplant recipients. The major complications resulted, there was one patient that was unrelated to the sleeve itself, but it was related to a simultaneous hernia that they performed, which resulted in an enterotomy and issues from that. And another patient required conversion to gastric bypass for persistent dysphagia. And in a larger group, they looked at the safety profile between doing the sleeve gastrectomy after a liver transplant and without a liver transplant. Looked at two groups. One had sleeve gastrectomy after liver transplant, another had sleeve gastrectomy, and they were not liver transplant patients. The complications were similar. There was less excess weight loss in the liver transplant group, presumably from the immunosuppressive medications, as well as the fact that they are less active after the liver transplant. They had a shorter hospital stay if they have not had a liver transplant, but the resolution of obesity-related comorbidities were very similar. The major complications in the sleeve gastrectomy group was 25%, including the need for sleeve dilation. All major complications in that group were related to poor oral intake, no liver complications, no alterations in immunosuppression. So my conclusions are bariatric surgery can be performed safely before, during, or after liver transplant. Performing it at the time of liver transplant requires a lot of coordination and a lot of resources, and it may be done in select centers. In our hands, we perform bariatric surgery before liver transplant in well-compensated cirrhotic patients, and we've also performed them after liver transplant patients. The adhesion profile is not very great because these patients are on immunosuppressive medications and steroids, so you can go in, it's not that difficult to do it. You just take down the adhesions, and the recommendations can't be universal, and it's very program specific. Thank you very much for the opportunity.
Thank you.
I'd like to invite the co-director of this course, Dr. Guillermo Macedo, to speak to us on what about hepatocellular carcinoma and NASH.
Well, thank you, Mr. Chairman. As long as I can hold this up. It's not here. So the issue today is to see what is the hepatocellular carcinoma doing with NASH. Do we have any new information on this? Yes, we do. In fact, as we're going to see throughout this outline, we're going to talk about this new entity. The ARTOS, formerly known as NAFLD, is now MASLD. We'll hear about the burden of obesity-associated liver cancer. We'll see about what we can do about surveillance of HCC in patients with obesity, the risk cofactors of HCC development in chronic liver patients, and can we really reduce HCC in this setting? For all baby boomers, this means something. The very last episode of MASH in 1980 had 100 million people standing. Probably it's the number at this time of MASH people. And we're going to see that MASH is really something that we should target. And recently in June, just a couple of months ago, there was a statement from the American Association and several other experts on this area saying that we will no longer use the previously exclusionary, negative, and confounder terms that used potentially stigmatizing language of non-alcoholic fatty liver disease and non-alcoholic steatohepatitis. Two stigma, in fact, fat and alcohol. Well, so what do we know about the new nomenclature, which is, in fact, where we are going to move from now on? There is a new term, the steatotic liver disease, We still have the term of steatohepatitis, which is an important pathophysiological concept to be retained. The old NAFLD is now the metabolic dysfunction associated steatotic liver disease, MASLD, and this MASLD encompasses patients who have steatosis and have at least one cardiometabolic risk factor. There is a new category which finally bridges one problem that you used to have. It's the patient that had some fat in the liver and some alcohol use or abuse. And now we call that the MET-ALD, which are the patients that also have some alcohol consumption. MASH, the metabolic dysfunction associated steatohepatitis, is the replacement word for NASH. Those who don't have any metabolic parameters and no known cause have cryptogenic steatotic liver disease. Confused? Well, don't be, because it's really simple. You have steatotic liver disease. Now, in that you have the metabolic, the MASLD. If you have some alcohol, you have the MET-ALD. And then you have all things related with steatosis, non-metabolically directly related. Drug-induced liver disease, hepatitis C, cryptogenic cirrhosis, etc. So, about this artist formerly known as NAFLD, it's not Prince, it's MASLD. It's the most common cause of liver disease at this time, almost 30% prevalence, which is a huge problem. And in 20% of MASLD patients, we have MASH. That means inflammation and variable degrees of fibrosis. One of the main causes of liver cirrhosis and most rapidly growing indication for liver transplant, as we just recently heard. And over the last 10 years, MASLD has been the most rapidly growing contributor to liver mortality and morbidity. MASLD is associated with metabolic syndrome, and the risk and the probability of having MASH, which is the bad news, the steatohepatitis, is related to the number of risk factors involved. And this is very important for the metabolic intervention. So increasing severity of obesity has been linked to increased risk of hepatocellular carcinoma, as we're going to see, and even type 2 diabetes mellitus by its own increases the risk of hepatocellular carcinoma. There is a continuum in the MASLD patients, the overweight or obese, or people with type 2 obesity, and with more than one metabolic cofactor. And then we have this movement from steatosis to steatohepatitis, coming back to steatosis or progressing to fibrosis and cirrhosis. There is a trend of progressing to cirrhosis if we don't have an efficient intervention in between. 5 to 15% of obese MASH patients progress to cirrhosis. And 5 of 25% of MASH patients with cirrhosis will progress to hepatocellular carcinoma. So we are dealing with an enormous problem, and so this is extremely important for our GI community and surgical community to be aware of this. Hepatocellular carcinoma is the 5th most frequently diagnosed cancer, the 3rd highest fatality rate of all cancers, and you have to know that almost all hepatocellular carcinoma arises from cirrhosis. As we see in that cheese, you see that the proportion of viral hepatitis and alcoholic liver disease, well, alcoholic liver disease is almost the same, but the viral hepatitis proportion is lowering. It's increasing the MASLD proportion. Now, if you see the annual incidence of HCC in MASH, it's much higher than patients without MASH. So MASLD is a risk factor, but much less than patients with MASH. So there is a clear evidence of a constant rise in HCC incidence, which is commonly attributed to the parallel increase of MASH. So the main factor here is cirrhosis. Cirrhosis, it's the premalignant condition to have hepatocellular carcinoma. There are all sorts of conditions creating the hepatocellular carcinoma, but MASH, this is the old slide, MASH is in fact the increasing condition to raising to hepatocellular carcinoma. Now, GI community has been, well, pretty much sensible to this issue, and nowadays we have been looking into all those links and molecular links between mast cell D, and hepatocellular carcinoma. And why is the GI community worried and concerned about this? Because obesity means for us lots of oncology problems in terms of the gut, as we all know, not only gut, but also pancreatic cancer, but finally and formerly liver cancer. It is well known at this time, and we can see geographically, there's a really connection between the proportion of HCC and NAFLD. And if we look especially at Middle East, there's a huge problem out there of relating HCC with MASH. And this is being a reality throughout the world. And furthermore, when you have increased BMI, even if you have other types of liver diseases, the risk of occurring the cancer-related mortality is much higher. So having fat in your liver is always complicated and troublesome. Now, there has been a meta-analysis of 9 observational studies, more than 1.5 million individuals, and that's showing that patients with obesity have twofold increase in HCC-related mortality, only with obesity. But, and people even treated with transplantation, there is an increased incidence of life-threatening complications in overweight or obese patients. So what we can see is that having fat in your liver really impacts everything, even the recurrence rate, microvascular invasion, and poor overall survival. Why is that? Is that so complicated that we can touch base on every single topic that we can move and we can have any type of intervention? Well, there has been lots of excitement around the molecular and pathways to understand why is obesity so much connected with hepatocellular carcinoma. I'm just going to point out a few of them. Insulin resistance, of course, essentially through the biological activity of IGF-1, the lipid accumulation and lipotoxicity, because they are clear drivers of inflammation. Some of the adipokines, especially because they promote the accumulation of macrophages, and that brings the pro-inflammatory and pro-fibrotic cytokines, which is the bad news for MASH. The endoplasmic reticulum stress, because of this positive feedback enhancement lipogenesis, and of course the oxidative stress. Also, microbiome is there, and this is clearly noticed since we can have, we can measure lipopolysaccharides in portal blood. We have lots of inflammation, particularly in MASH patients, coming from the cytokines from the liver tissue, but also from the fat itself, because of the autophagy, which is the lysosome-dependent catabolic process, and with the profibrogenic properties in hepatic stellate cells, the hepatokines, the new hepatocalcin, the ANGPTL8 and the FAT-Win A and B, and genetic factors, and of course some epigenetic modification through the modification of DNA methylation, histone modification, and microRNA. So this is really a problem for us. The GI community is looking thoroughly into what is happening in terms of obesity, MASH, MASLD, and hepatocellular carcinoma. And we need to find out the perfect therapeutic targets. This is not to confuse yourself. This is just to mention that there are many potential therapies, many potential targets. The drug industry is looking thoroughly into these targets. So this is something that we will have in the coming future. We are now understanding very well the biomolecular pathways towards HCC development. But is that only the development that we care of? No, there are some other issues that we need to take into consideration. One of them is the screening and surveillance. It is difficult to screen these patients for HCC. Cirrhotic patients, we do have clear and firm guidelines saying, okay, we need US every 6 months and alpha-fetoprotein. But in patients with MASLD, this is suboptimal because almost more than half of the HCC patients are not diagnosed by screening, and they do present with liver-related complications instead. So probably abdominal ultrasound is not as sensitive as an early detection tool, since the presence of fatty liver disease and obesity hampers its performance. But that's not the only case. We also know that we could look for HCC in patients that don't have cirrhosis, but it's no use. I mean, the burden is so big with the MASLD patients that we do not, well, I wouldn't say care, but we don't mind of having a specific program over the non-cirrhotic patients. We need to look into the cirrhotic or MASH patients to have these screening facilities. What do we do when we find out the HCC? Well, we treat them as we generally do. We have the BCLC staging process, and we try to sort of the best decision to approach. But we need to be aware always that generally MASLD HCC patients have generally a worse prognosis than those who have HCC related to other etiology, because they have more advanced stage of disease at diagnosis and because they have, of course, many other comorbidities. One thing that is very clear to us and very disturbing is that these patients do not have a formal continuing program, effective program of surveillance and screening. And when we see that's mainly eventually because of the stigma. Our patients with alcoholic liver disease or viral hepatitis, they do get better screening than MASLD MASH patients. And this is something we need to reflect on. When you follow patients with hepatitis C cirrhosis or hepatitis B or any other reasons that bring them to have hepatocellular carcinoma, well, in fact, the risk is every time higher when you have fat in between. And this is really something that we should take care of, people that take care of liver disease patients. So this is a summing up of what we can do about therapeutic options. Well, it's not wishful thinking. When you have too much targets, that means that you don't have the best target at all. But this also means that, in fact, we have to compile several options in terms of intervention. And of course, at this time, bariatric surgery or metabolic surgery, endoscopy, they are really very important tools, specifically if they address the MASH patients. So in conclusions, we can say that with the growing epidemic of obesity, a parallel increase in MASLD is foreseen. It impacts the risk of HCC by exacerbating the onset and progression of MASLD, and it's associated with reduced survival in HCC patients. This also might be related to this less efficient surveillance strategy and consequent delay in diagnosis with much more limited probability of therapeutic interventions. Of course, we need to take this holistic approach, combining lifestyle, pharmaceutical, and/or endoscopic surgical therapy that most likely will yield superior long-term HCC prevention through durable and sustained weight reduction. We have to target MASH patients. So that's why that we feel that improving this mechanistic understanding of the impact of these therapies in liver health may allow new insights into the therapeutic targets for MASH treatment and HCC prevention. And hope to find you somehow, somewhere soon with a WGO and IFSO meeting somewhere in the near future in Porto, Portugal. Thank you very much.
The last speaker up to the podium to discuss bariatric metabolic surgery versus lifestyle intervention plus best medical care in non-alcoholic steatohepatitis, BRAVES, a multi-center open-label randomized trial. And that's Dr. Lydia Castagno.
Sorry. Always
You have to wait. Then
not going, non funziona. Not work.
Okay.
Hey there.
I think. Okay. Thank you for the presentation. I would also like to thank Professor Angrisani for his kind invitation. So I'm going to present the results of our multi-center open-label randomized controlled trial regarding bariatric surgery versus lifestyle intervention plus best medical care in the treatment of non-alcoholic steatohepatitis. This study is also known as the BRAVES trial. I have no disclosures. So there is already extensive evidence available in literature regarding the effectiveness of bariatric surgery compared to medical therapy in the resolution of type 2 diabetes, both in the short and long term. And a large proportion of such evidence is represented by randomized controlled trials, hence level 1 evidence often published on very high impact journals. On the contrary, when it comes to non-alcoholic fatty liver disease or steatohepatitis, such high-level evidence is quite limited. Nevertheless, non-alcoholic fatty liver disease is the most common cause of chronic liver disease worldwide, affecting more than half of those subjects with type 2 diabetes and up to 3/4 of those with obesity. It has been estimated that by 2030, NASH will affect as many as 27 million people in the USA alone. And weight loss is indeed recommended in subjects with either NAFLD or NASH, but there are currently no specific surgical or pharmacologic interventions for these conditions. And no drugs have yet received approval by either the FDA or the EMA as a treatment for NASH, although some drugs are currently under phase 3 trial. There have been a few observational studies showing how bariatric surgery appears to induce dramatic improvement of both NASH and fibrosis. Specifically, Lassie and his group were able to demonstrate how NASH can resolve in up to 84% of liver samples in patients with severe obesity 5 years after surgery, with an improvement of liver fibrosis in 70% of participants. And similar findings were also reported in a smaller observational study published subsequently. And we can see how NASH resolution exceeds 90% with a BMI loss greater than 10 points. And fibrosis can regress to an F0 stage in more than 60% of patients at 5 years after surgery. So the aim of our open-label multi-center randomized trial was to investigate and compare the efficacy and safety of bariatric surgery with lifestyle intervention plus best medical care as a treatment of histologically confirmed NASH. So the primary endpoint of our study was the histological resolution of NASH without worsening of fibrosis. Secondary endpoints included the improvement of fibrosis of at least one stage without worsening of NASH, the NAFLD activity score improvement of at least one grade, worsening of fibrosis, diabetes control, lipid profile, and safety profile. A post-hoc analysis was also conducted in order to further assess the primary endpoint as well as the main secondary endpoint, especially in those patients with severe NASH at baseline, so with a NAS score greater than 4 or F2, F3 fibrosis. So participating centers in our trial were 3 large hospitals in Rome, Italy. We included 3 interventions, so 2 surgical interventions, either a Roux-en-Y gastric bypass or sleeve gastrectomy, and a medical care group. We used a pairwise comparison approach, and we planned for 3 comparisons, so either between the 2 surgical groups or between either surgery and medical care. We calculated a sample size of 77 participants per group, and considering an attrition rate of 20%, we enrolled 96 participants in each group for a total of 288 subjects overall. We screened subjects with obesity, with a BMI between 30 and 55, with or without type 2 diabetes, with an age between 25 and 70 years. To determine the likelihood of NASH and liver fibrosis, we used the NAFLD fibrosis score, or NFS, with a cutoff greater than -1.455, which is an excellent negative predictive value, giving a very high probability of fibrosis and NASH. In those subjects with a cutoff above the one mentioned, we performed an ultrasound-guided percutaneous liver biopsy, both at baseline and 1-year follow-up. And we used the NAFLD activity score, or NAS score, which is the algorithm proposed by the NASH Clinical Research Network. And biopsies were reviewed using the score by 2 expert hepatopathologists. The patients enrolled in the study had at least 1 grade of hepatocyte ballooning and of inflammation, and at least 1 grade of steatosis and fibrosis F1 to F3. We included all those subjects with a NAS score greater than 3. as the FDA guidance at the time of the study actually recommended including a NAS score greater than 3 in NASH trials. However, the most current FDA guidance actually now advise a NAS score greater than 4 to be included in NASH trials. We excluded all those subjects with major cardiovascular events in the previous 6 months, liver cirrhosis, end-stage renal failure, pregnancy, major metabolic conditions which could affect liver function, and interfering medications. This is a flow diagram of our study. So we assessed patients for eligibility between April 2019 and June 2021. This study was actually meant to last approximately 1 year. It lasted twice as long due to COVID-19 pandemic. We finally screened 431 subjects. 24%, 103 subjects, were not eligible because of the absence of NASH. The remaining 76% actually had a variable degree of NASH. 9% declined to participate, while 67% were deemed eligible for the study. So we randomized 288 patients and allocated them in one of the 3 groups, so root-and-wide gastric bypass, sleeve gastrectomy, or medical care. We followed up patients for 1 year, and we finally analyzed 77 patients in the Roux-en-Y group, 79 in the sleeve gastrectomy group, and 80 in the medical care group for a total of 236 participants, 82% of the initial 288 who fully completed the trial. So down to our results. Patients in the 3 intervention groups did not differ in terms of age, NAS score, fibrosis score, or liver function tests. However, there was a clinically small but statistically significant difference in terms of weight and BMI, which was greater in the gastric bypass group compared to the other 2 intervention groups. This could explain, at least in part, the greater weight loss that occurred in the gastric bypass group compared to sleeve gastrectomy and obviously to the medical care group. Sleeve gastrectomy was anyway superior to medical care in terms of weight loss outcomes. Nevertheless, this did not affect our primary and main secondary endpoints. In fact, NAS score, the NAFLD activity score, improved significantly after both sleeve gastrectomy and gastric bypass compared to medical care, and there was no difference between the 2 surgical procedures in terms of NAS score improvement. It was approximately 4.11 across the 3 groups. It went from 4.18 to 1.99 in the sleeve gastrectomy group, 4.21 to 1.82 after the gastric bypass, and 4.21 to 3.45 in the medical care group. Similarly, those patients with fibrosis F1 to F3 had a significant improvement in fibrosis, in all stages of fibrosis, after both surgical procedures compared to medical care, and there was once again no difference between surgical procedures. And the same can be said in terms of liver function, which significantly improved after both surgical procedures, and this did not occur after medical care. We performed an intention to treat analysis, and we found that those subjects who met the primary endpoint were 56.2% and 57.3% in the gastric bypass and sleeve gastrectomy groups respectively, compared to 15.6% in the medical care group. Those subjects who met the main secondary endpoint, so the improvement of at least 1 stage of liver fibrosis without worsening of NASH, were 36.8% and 39.4% in the gastric bypass and sleeve gastrectomy groups respectively, compared to 22.9%. If we look into the per protocol population, the results were quite promising. So approximately 70% of patients in both surgical groups had a NASH resolution without worsening of fibrosis, compared to approximately 19% in the medical care group. And also in terms of liver fibrosis, these results are still only 1 year follow-up. We will be publishing the follow-up at 3 years, but already at 1 year follow-up, we found a regression of at least 1 stage of liver fibrosis in 46.1% and 47.4% in the gastric bypass and sleeve gastrectomy groups in those subjects who actually reached the end of the study, and 27.5% in the medical care group. The calculated probability of reaching the primary endpoint was 3.6 and 3.67 times greater in the gastric bypass group and the sleeve gastrectomy group, respectively, compared to medical care. Stratifying by sex, women had a greater probability of reaching the primary endpoint compared to men. Those subjects without type 2 diabetes had a greater chance of having NASH resolution compared to those who actually had diabetes at baseline. And those subjects who had more severe NASH at baseline, so with a NAFLD activity score of at least 4, had a greater probability of having NASH resolution. Once again, in the per protocol population, we see even more promising results. So the relative risk of achieving the primary endpoint was 3.74 and 3.71 times greater in the gastric bypass and sleeve groups compared to medical care. Patients in the surgical groups were twice as likely as having a NAFLD activity score improvement of at least 1 grade compared to the medical care group. And in the post-hoc analysis, we can see that patients with more severe NASH at baseline had a greater probability of having a resolution, with those subjects receiving gastric bypass having an even greater probability of reaching the primary endpoint, even compared to sleep. From a metabolic point of view, we also evaluated the metabolic profile. Patients across the 3 groups had the same prevalence of type 2 diabetes at baseline. However, diabetes control was different at baseline between the 3 groups. Diabetes control was worst in the gastric bypass group, followed by the medical care group, and it was best in the sleeve gastrectomy group at baseline. Plasma glucose levels improved significantly after gastric bypass, as did insulin resistance, and also plasma concentrations of triglycerides, LDL, and HDL cholesterol compared to the other 2 groups. Diabetes remission, defined as an HbA1c lower than 6.5% without ongoing diabetes medication, occurred in 6% in the medical care group, 68% in the gastric bypass group, and 65% in the sleeve gastrectomy group. So responders, those patients who achieved the primary endpoint, were those subjects who lost more weight, had higher rates of diabetes remission, had a greater improvement in glycemic control, insulin resistance, and transaminase levels compared to non-responders. We evaluated percent weight loss and actually found a threshold which influenced NASH resolution. In fact, the percentage of patients with NASH resolution increased almost linearly with the degree of weight loss up to 20%. Above 20% weight reduction, the increase was nonlinear, indicating a relatively smaller influence of weight loss on NASH resolution rate above a 20% weight reduction threshold. And finally, safety profile was evaluated. There was no mortality, no life-threatening complications across the 3 interventions. Surgical procedures had a greater rate of complications compared to medical care. However, there was no difference in complication rate between gastric bypass and sleeve gastrectomy, and surgical complications were all treated conservatively or non-operatively. So in conclusion, bariatric surgery is more effective than medical care in the treatment of NASH. The ability of surgery to control and even improve fibrosis associated with NASH is of particular clinical relevance, given the fact that fibrosis is the main predictor of liver complications and cardiovascular mortality and morbidity. And finally, NASH should be considered as an important factor in decision-making around prioritization of surgery in people with obesity and type 2 diabetes, as currently there are no mechanisms of prioritization of bariatric surgery in most healthcare systems. Thank you.
Thank you, Lydia. Please stay here, and I'll invite all the presenters also to join us at the table, please, so that the audience can address the proper questions to you. Go ahead. Scott. So we are taking questions from the floor. Thank you.
Hi.
Go ahead.
My name is Francesco Papadia from Genova, Italy. First of all, congratulations to all the panel for the excellent presentations. I have 2 questions. A comment about the influence of bile acid malabsorption after bariatric surgery. Bile acid malabsorption after bariatric surgery and its effect on progression of liver disease and liver decompensation. Because in the surgical literature, those admittedly very, very rare cases of liver decompensation after bariatric surgery, to my knowledge, happen mostly or only after derivative surgery, where there is some kind of biliary malabsorption. So a comment on the attitude, on the surgical attitude, which operation to choose in liver decompensated patients. The second question is to Dr. Castagnedo, which is a wonderful presentation of a wonderful paper. And I was very intrigued by the data that 20% of weight loss was probably sufficient to give the effect, because 20% of weight loss is in the same ballpark as the new drugs. So a comment also on that. Thanks.
Exactly. It's a great point. Yeah, it's actually most drugs are able to produce 20% weight reduction. And some studies have shown that actually medical care, best medical care, so latest generation weight reduction drugs are able to lead to a 20% weight reduction. And they're able to generate significant resolution of NASH. And this was actually proven. However, they did not manage to prove fibrosis regression. So probably surgery is able to induce fibrosis regression, which in our case was only 1 year postoperative follow-up. So probably we did not see as much as we wanted, but probably at 3 or 5 years we will see even more. And it might be that surgery can induce fibrosis regression with different mechanisms compared to simply weight loss, which can be induced by weight reduction drugs. So they can help on NASH, on the inflammatory part, but less in the fibrosis part.
So, as far as the surgery question was concerned, I think the number one thing, I mean, this is part of my talk tomorrow, but the number one thing is we got to recognize that you cannot tell the degree of fibrosis or steatohepatitis without a biopsy. We always underestimate the presence of really advanced fibrosis by just looking at the liver. So personally, I have been burnt by this. I did a SADI on a patient who had like a liver which looked very fatty, and he was a BMI of 75. It looked very, very fatty, but did not have any evidence on my visual of cirrhosis. So I did a SADI, and he, in 8 months, became frankly cirrhotic. And then we listed him, but it was too late. He developed some complications and passed away. So I think the safest surgery in this cohort, without a doubt, is sleeve gastrectomy. There are reports of Roux and gastric bypass causing this, and nobody still knows what the reason is. Is it loss of some of those medium chain, branched amino acids? Is it bile loss? There's a lot of speculation. But I think if you are in that situation, always biopsy and do a sleeve gastrectomy.
Yes, go ahead.
Yeah, can I just make a little comment on the 2 points? So the devil is in the details. So just the first point about weight loss. I think we have to be careful because we cannot compare pears and apples. This study, beautiful study that was presented, is in NASH patients. This is a very, very specific subgroup with a lot of diabetes. Prevalence is very high. And we know that diabetes per se is an independent factor associated with less weight loss. So having this amount of weight loss in these patients is not like in this very well marketed drug paper. So it's not the same 20%. Just a word of caution. We have to be careful. Time will tell. But we have to be careful to not compare between papers. It's not the same thing. For the last point, I think, again, we have to be careful of association. Okay, bile loss. Okay, bile acids. But just a very simple thing. These patients have all protein malnutrition. And this severe liver disease is always associated with very low albumin or prealbumin levels. And that's, I think, the major point. They are severe denutrition. So you have fancy things like bile acid, but I think a very simple thing is severe denutrition and protein denutrition. And that's where you have, and this is ascites, anasarc. These patients are very special, and they end up in liver transplantation for a totally other reason. Just these two little aspects.
It's curious to see that a few years ago, getting the liver tests almost normal was a kind of a surrogate marker of an efficient intervention. But nowadays, liver function tests are not a surrogate marker, but are the main target for many of these procedures. We should take care of the liver. That's my message from my, let's say, organization and my corporation of gastroenterologists and hepatologists. But do you think that really we should focus on before a decision of a specific type of intervention to know exactly how the liver is? Because for us, liver biopsy is still the gold standard, not only for NASH, but for MASH. I hope that you get all the idea from today on. Whenever you see NASH, please cut that off, and NAFLD and stuff. So remember, MASH, it's important to define MASH, but it's also important to define if there is inflammation or fibrosis. What do you think about that?
So I think that's a great point, and I have become more cognizant of it. I do get liver function tests preoperatively, and if the patient is super obese, then I do, or have very high degree of visceral obesity, even if they have a BMI 40, but they're all pot-bellied, then I do get an ultrasound of the liver, and if they document a fatty liver, then I intraoperatively, I get a consent preoperatively for a liver biopsy and get it approved, and then do an intraoperative liver biopsy on this patient. And I have not taken it to the level of, can I get an immediate result? Obviously, if you see cirrhosis on the liver, that's an easy answer. You do a sleeve. Would I alter the procedure now? I probably would not do a very aggressive procedure if I think the liver is even borderline fibrotic. I will just stop with the sleeve. And a lot of these patients, we also have the benefit of going back. If you look at these patients, my SADI patients, my DS patients, I don't do the gallbladder at the same time of the surgery. If they have a gallbladder, I usually get an ultrasound at 6 months. If they have sludge or stones, I go in and take it. At that time, I repeat the liver biopsy. That's been my practice right now. I have been burnt by that case where I thought I knew what I was looking at, and one case is enough for you to change your entire perspective on this.
Thank you. Great comment on this. Any further questions about this? Yeah, go ahead.
I have 2 questions specific to liver transplant and sleeve gastrectomy. If you're unable to perform the liver transplant with inline biliary anastomosis and have to do a Roux-en-Y, would that cause you to abort the sleeve gastrectomy?
Come again?
If you have to do a Roux-en-Y for the biliary anastomosis and the liver transplant, say you can't reach the duodenum, will you abort the sleeve gastrectomy in those patients?
Yeah, so I think I have not come across that particular situation, but yes, the sleeve would not be the ideal procedure in those patients. Perhaps constructing another Roux, a double Roux, and doing a Roux-en-Y gastric bypass would be the solution to it. Having said that, people are always worried about immunosuppressive medications after a Roux-en-Y gastric bypass in transplants. Roux-en-Y gastric bypass is not a malabsorptive procedure. I want you to understand it. Unlike the SADI and the switch, you can maintain very good immunosuppressive levels with the Roux-en-Y gastric bypass. The only problem about a Roux-en-Y gastric bypass is loss of access to the biliary tree. which is the reason why I prefer the sleeve over the gastric bypass. It's not because I think they can't maintain immunosuppressive medications. You can maintain immunosuppressive levels very well with the Roux-en-Y gastric bypass. But loss of the biliary tree axis and not being able to go into the biliary tree to have good access to that, that's the reason why we choose a sleeve. But in that particular situation, which I've not come across, I would do a double Roux.
My second question, do you find that there's increased cell sept intolerance in the patients after sleeve gastrectomy? That would be my main concern. I have a lot of patients that we obviously don't do bariatric surgery on at the same time, but have had the sleeve gastrectomy done before transplant, and I've noticed just anecdotally they have a higher level of intolerance to the cell sept.
Yeah, I mean, I think that's definitely a consideration, but I don't think, unless you can play around with the medication, and maybe those patients might be better candidates for another one of the medications, that's the only thing you can do.
I certainly don't want to be provocative to your liver transplant group, but one thing that we used when we had problems with cell sept was using azathioprine. Because at the end of the day, mycophenolate was just easier, well, slightly better tolerated, if better tolerated, because of those gastric problems. So let's go back to the previous immunosuppression. That's okay. One comment on a cautionary note I would like to have is about the particularly challenged MASH patient with type 2 diabetes. This is the risk group for liver cancer. I would say the worst group for having a liver cancer. Do you have any particular program of screening, let's say, pushing your GIs or your radiologists to perform US to look for it, or are they just there in a regular program of screening as a usual cirrhotic would have?
So again, that's something that you can assess in the clinic by just visceral obesity. If I see someone with high degree of visceral obesity, then a liver ultrasound I will definitely push for, and maybe even a liver stiffness test like a TEG to try and see what the liver stiffness is, and if that is very high, then they get an intraoperative biopsy, and then I will do only a sleeve. So I think we should go away from BMI, because you can have an African American woman with a BMI of 80 with I'm not kidding you, not a single comorbidity. I will be asking them, do you have this, do you have this, do you have this? None. And then you have a South Asian gentleman with a BMI of 35 who's got everything in the books, right? So it has to be based on ethnicity and the distribution of fat.
Thank you. We still have time for one more question if someone is popping up with a... Yes, go ahead.
I'd like to ask Dr. Higa. Dr. Higa, you have a vast experience, so would you like to comment on any personal experience on cirrhotics, which you've had done a bypass and they become cirrhotic, or...
Yeah, I have. Like you, I've had some anecdotal experience that scares me a lot. I had an early patient, was not especially cirrhotic, but bad enough to where I did a bypass. This is before the time, this is before sleeve era. Mm-hmm. And I purposely left a G-tube in case the patient got into trouble, I could feed them enterally to stave them off from liver failure. I left town, and unfortunately, they never used the G-tube. The patient went to pulmonary hepatic failure. We transplant, we sent the patient off. But these things, that unknown, because as we all know, the other end of the spectrum, the severely malnourished, the protein calorie, they become cirrhotic as well, and I don't know how to deal with that. And I was thinking, achieve them medically now without having to resort to surgery, which I think would be the best way to take care of these patients. But I often wondered, even if it's a simple sleeve, if these patients are better off in a transplant center with all of the knowledge they have, rather than even in a practice such as mine where we do high volume, but still we don't do transplants. I'm still thinking that we can tee them up, send them to a transplant center, have their sleeve done. We can still take care of them. What is your thoughts on this?
No, I think, I think that's a great idea. I think working with the transplant team or sending it to a transplant team might be the best way of dealing with these patients, or at least working with your hepatologist. I think our assessment of liver disease is very, very poor in our hands, in surgeons' hands. So I think we should be more aggressive screening these patients for liver disease. And the other thing I want to mention is, many, many years ago when people were doing GI bypass, you would get the cirrhotic, and then the thought was that these patients had bacterial overgrowth. Now, in all the modern procedures that we do, we don't have any blind loops. We don't have, but we still have a significant number of patients who become cirrhotic if you do a hypoabsorptive procedure. So the reason is as he mentioned, is protein-calorie malnutrition. So if you do a very, very restrictive sleeve on these patients and you induce protein-calorie malnutrition in these patients, they will become cirrhotic. It's the same model as someone with kwashiorkor. If a kid has kwashiorkor, even though they are completely malnourished, you'll see that their liver is huge, and they become cirrhotic. It's almost like a fatty liver disease that happens even when you have acute protein-calorie malnutrition. So if somebody's albumin starts dropping or they start developing anasarca, be quick to recognize it. Put in a G tube if you've done a bypass. Put in a J tube if you've done a SADI or a sleeve.
One more thing, because we had several talks today about limb lengths and bypass, because we never made it the standard of care to measure the entire small bowel length on every patient. And there's no good way of preoperatively staging these patients, as you point out. And the FibroScan is not very accurate, ultrasound, etc. There's really very little risk to doing a liver biopsy on every patient, on every time. I think maybe our society should make this a standard so we get some ideas. And I heard you very cleverly go after the gallbladder afterwards to see what happens, and that's brilliant. And even at that time, because we review op notes all the time from non-surgeons. Patient looks cirrhotic. I took out the gallbladder. I didn't do a liver biopsy. I don't know why. But again, that was me before.
Yeah.
The same thing.
That's because it's not in our radar enough. And no, it's actually 5 RVUs if you get approval. If you can demonstrate you're screening a very high-risk population, and if you can screen with an ultrasound and it shows a fatty liver, which it will if you, and you can actually get pre-approved, and it's 5 RVUs, you can add to your procedure if you get a pre-approval. Now, I haven't been aggressive about getting those RVUs or anything. I just do it. I just get a consent and do it. But if you want to be really aggressive about it, and then we also have to, as surgeons, if we are operating on this population, we need to get more familiar with what the gastroenterologist, these scores, this fibrosis scores, those are not very hard to do. Just with the plug in the lab values and be more scientific about it.
Almost that, but the fact is this is a very good reason for this continuous partnership between IFSO and WGO. So, Scott, will you take it?
Yes, I want to thank my co-director for this, Dr. Ms. I thought my voice would be loud enough. I want to thank Dr. Macedo, my co-director of this. I want to thank the speakers. They all did a great job, and the audience for sticking it out, and have a great night. So I think it should be the end of the session.
Thank you. Thank you very much.
Hello? Hello? Yes.